Kimberly Hendricks is here. Kate Nath. And Dana Harganani is excused. Tim Harmon.
Here.
Sean Parkman.
Here.
Mark Perlman. Saban Martin.
I'm here.
Good morning. Jeremy Vandehey. Senator Betsy Johnson. Representative Andrea Salinas. Okay. Mark, were you able to join us? Mark Perlman?
Like we're one short of a quorum, Kimberly, so we might need to wait a few minutes.
Yeah, Kate Nath, were you able to join us? Okay, well, we will, do you want to just go on to the COVID-19 updates and skip the minutes for now? Oh, hey, I see Jeremy. I see that face. Good morning. You're gonna go off mute and say good morning, Jeremy?
Oh, good morning. Can you hear me now?
We can hear you now.
Sorry, my headphones were connecting, so I said hi, but I don't think you came through.
No problem. Good morning. Okay, so now you have 4, Ali, and so we're still waiting for Kate and Mark.
We actually do have 5 now, so we're good.
Oh, okay.
So I'm happy to make a motion on the minutes since we have enough folks here. And I make a motion that we approve the minutes from our July meeting.
Thank
I'll
you,
second.
Saban. Was that Sean? Sorry, I missed who was seconding.
Jeremy, I'll second.
Oh, Jeremy, thank you. Good morning. Okay, so we have a motion on the floor to approve the minutes as presented in our packet for the July 20th, 2021 meeting. Do I have any questions? And so let's go ahead and I better do a roll call vote. So Kate Nath, still not here. Kim Harmon.
Yes.
Sean Parkman.
Yes.
Mark Perlman, were you able to join yet?
Yes, I'm here.
Oh, good morning. Good morning, Mark. Saban made the motion.
Yes.
Jeremy second. Okay, looks like a motion. Any opposed? Looks like the motion carried to accept the minutes as presented in our packet. Okay, so now let's move on to, we have COVID-19 vaccine updates. And first up is Kaiser Permanente with Dr. Keith Bachman and Sapari Sturdivant.
Great. This is Keith Bachman. Good morning. Happy to present an update. Well, not happy to related to COVID. It's obviously been a very challenging last couple of weeks, and we expect more challenging weeks through the next few weeks as we see where this latest surge, the 4th surge in Oregon, plays out. It's really sort of unprecedented at this time in the state, with a 53% increase statewide in case positivity, 1,800 cases in Oregon daily average, which is a marked increase over 1 and 2 months ago. A state positivity rate of 13.6%. And really we're seeing increasing challenges throughout the Oregon community related to hospital staffing, ER staffing, related to wait times, and increasing need for diversions. So it's a complicated time. Our projections going forward, we are seeing an increased fall wave, equivalent or more than the spring surge, but with less certainty about the timing and when it's going to peak. The uncertainty relates to the infectiousness of the daily variant, the changing social distancing and masking practices in the community, as well as return to school. As we are seeing, as other hospital systems reported, hospital staffing an issue with challenges attaining ideal ratios, particularly with nurses due to burnout and attrition. Our Kaiser hospitals are at their peak capacity, actually the highest census that we've ever been at. This is partly related to COVID and partly related to other factors leading to increased utilization. Our COVID-related inpatient census in Kaiser Permanente hospitals is up from 100% from last week and is currently 32. Related to these challenges, we had a big leadership summit yesterday, which include clinical leadership, medical group leadership, administrative representatives, labor representatives, to develop a comprehensive plan related to how we're going to manage the next several weeks to continue to provide safe and optimal care. Certainly applauding the work going on at the state level, Governor Brown's announcements related to mask mandates and requiring vaccination for state executive branch employees. We have also have a mandate for all Kaiser Permanente employees to get vaccinated, and we think that's the right way to go. Some just vaccination and testing updates. Currently 95% of the medical group physicians have been vaccinated, and almost 80% of Kaiser Permanente employees have been vaccinated. By September 30th, our mask mandate goes into effect with all employees and clinicians must be fully vaccinated by that time. We do see some positive statistics around vaccination. When we looking at demographics of vaccination by age, we're seeing greater than 80% of individuals aged more than 65 having been vaccinated, and greater than 70% in the 45 to 64 year age group. There are less vaccinations in those age 16 to 44, with around 60% vaccinated, and 12 to 15 over 50% vaccinated. So certainly more room for improvement in younger people to get vaccinations. We're carefully following disparities related to race and ethnicity. Currently, Asian and Pacific Islander Kaiser Permanente members have an 82% vaccination rate. Those identified as white, 74% vaccination, 5% less in American Indian and Alaska Native at 69%. About the same for Hispanic and Latino, and then Black individuals at 63% vaccination rate. So significant variation also by race. We see significant variation by Kaiser Permanente region in Oregon, with those in the west side of the Willamette River at 80% vaccination rates, and east side 77% vaccination rates, and in Mid-Valley 66. So 1 in 3 individuals in Mid-Valley have not yet been vaccinated. PEBB members are doing better, with 77% of PEBB subscribers being vaccinated, which is an increase by 3% since July 11th, and 71% of PEBB members, which includes dependents, being vaccinated as of July 11th. Overall PEBB testing for COVID, these are being done prior to certain kinds of procedures for symptoms or done for travel. There's been 1,322 tests done per month with a positivity rate of 6%. In terms of PEBB members being hospitalized, we can see actually trends going down in the right direction. I would imagine partly relates to increasing vaccination, which we know is quite effective at reducing serious COVID illness and hospitalizations. In April, there were 14 PEBB members hospitalized, including 4 ICU cases. In June, that went down to 10, and in July, 8 with 0 cases in the ICU. Other just note, the big news this week was the recommendation of a 3rd dose of an mRNA vaccination for individuals who had an initial series of mRNA vaccines, and that's for people with immunocompromise, including transplants, cancer chemotherapy, and on immunosuppressive medications. And we're aware of these documentations, and we're working through an implementation plan for that. I'm also pleased to announce that Kaiser will be participating in a clinical trial for children aged 6 months to 11 years. And so we'll be recruiting soon. I think I'll turn to Sapari for any other comments.
Yeah, just thank you. I just wanted to give everyone a quick update that, we are continuing to support our employers and agencies. We are sharing resources for testing and vaccinations. And in our latest communications, we shared and reminded our employers and agencies that all members and non-members can get vaccinated at Kaiser Permanente. Appointments can be scheduled online, and we have an immense amount of resources, toolkits available to support and help encourage vaccinations. We also have many flyers in many languages on vaccine safety and effectiveness, what to expect when you're getting a vaccine. And so what I'll do is I can put in the link, a link to the resources page. So feel free to tap into that if you need it for any reason to support your communications. And that's all we have. Any questions for us?
This is Sean. I have a follow-up question, and I have the same question for all of the
All
carriers.
three.
So, which is, to your knowledge, are you observing kind of cumulatively over the year, but now especially in this sort of resurgence of the crisis level activity, a reduction in your workforce? So like just the attrition of nurses, I don't know, like to the level of an exodus, but some kind of, are you concerned about recruitment, retention? What are you seeing in that sense?
Yes, I think it's a supply and demand issue. Yes, there is loss of nurses and other staff due to burnout, due to competing priorities with childcare at home, due to fear of immunosuppressed or other high-risk people and their families, and concern of being an environment more likely to bring that home. Though the reality is the likelihood of transmission of COVID in healthcare settings has luckily been quite low. As well as increased demand for care, both related to COVID and for other clinical issues that were put off over the last 18 months. I don't know if that answers, and we can provide other information on what the expectation is going forward. Unfortunately, everybody is in the same situation. So the usual kinds of things that we might do about redeploying staff from facility to facility or using agency nurses is a challenge because everybody's in the same situation. That's my understanding of it. We can provide more detailed information as to where things stand. Sapari, anything to add with that?
No, just to reiterate what you shared this morning, Dr. Bachman, that we are, Sean, looking at this as an organization. And the meeting that was held, earlier this week with labor representatives and management representatives, the leaders, we are trying to plan for all of that.
And just to thread the needle, negotiate the optimal strategy in a difficult situation. I mean, I think that we don't want to go back to canceling elective cases and things like that. We also have to be prudent in how we use hospital resources and making sure we have the capacity to take care of the most critical situations and the uncertainty going forward where the surge is leading us.
Jeremy has a question.
I think so. The question I have for everybody, I'll have the same question for everybody as well. And I really want to hear about, I think it's great that our vaccination rates are sort of on par with the statewide average, but I'd really like to hear what each of the carriers are doing to reach out to those unvaccinated members and families. And, it's great that there's toolkits online, but this clearly requires folks hearing, more proactive information than, misinformation they're hearing on the internet. So what is KP's strategy for reaching out to PEB's unvaccinated members and, informing them of risks and helping facilitate getting vaccinations?
Yeah, I mean, so we're using a population-based approach like we would use for most conditions, not necessarily a group-specific approach, but people at the highest risk based on clinical risk as well as demographic risk. are getting outreach calls from clinicians. We pulled in some retired physicians to help with this, and pulled in some other people that are otherwise seeing patients to make those phone calls. So we're kind of going through that way. Certainly when people do present for care, they're going to get a conversation about that as well. It's pretty easily displayed who's been, because of the success of our vaccine registry program, and that data is really fed back into all our members' charts. We really know quite well who's been vaccinated in Oregon and who hasn't been vaccinated, so we can target those conversations. They're not easy at this point. People that don't want to be vaccinated are not getting vaccinated, and they're pretty aware of the issues and the risks. However, we're having successes, and we share those, and we can have a positive conversation. We can have members who are being mandated by their employer to be vaccinated and are willing to begrudgingly getting it done then. We have people who are affected, have had family members affected, and now see the need for vaccination. We have people who are just getting the better educational push from clinicians and other sources. So it's challenging work. It's we need to be sensitive. We need to be careful. We don't want to turn people off so much that they don't want to present for other kinds of care, but we need to give a strong message.
Can I ask a
Thank
follow-up?
you. Yes. Go ahead.
So I'm just curious. Have you? So you're doing this across all populations, not looking at PEBS population specifically. Do you have targets or benchmarks, things that you're shooting for in terms of trying to get to close the gap?
I haven't heard it. I mean, obviously we want to get as many people vaccinated as possible. So I think the target's 100%. So I don't think in our situation, it's just the more the better, and aiming at the highest risk people.
And I also just wanted to add that I think we've shared in past updates that we are supporting a lot of community efforts, community organizations to help reach those hard to reach individuals.
Thank you. Okay, so now the next group up is MODA. So we have Dr. Robin Singh and Erica Hedberg. Sorry, I don't want to Hedberg. Don't want to butcher your last name. But do you want me to remind you what the two questions are that they want added in, or did you get those?
Dr. Singh, did you get the questions? Oh, you're on
you're
mute.
On mute.
Thank you. Is that related to the sort of our vaccine efforts, strategies, our staffing as well? Were those a couple of the questions?
Perfect. Thank you.
Yeah. Should we kick off with the update, and we can then also address the questions and the excellent discussion, if that works? Thank you. So similar update, unfortunately, to our colleagues at Kaiser. They'll try and add some additional data and perspectives. So globally, we're seeing 208 million cases, 4.5 million deaths. That's almost 1 million more than just a couple of months back. So there is a full-blown fourth wave, cases rising across the world. And nationally, we're at 36 million cases with approximately 610,000 deaths. So cases are soaring across the country with over 180,000 per day, representing more than 10-fold increase over the last month or two. Over the last few weeks, all 50 states have reported a large upward increase at some stage. Weekly hospitalizations are up several 100%, and hospitals are at capacity in many cities across the country. Deaths come some days and weeks later, though are now also rising and are averaging over 600 cases a day. The CDC director is referring to this as a pandemic of the unvaccinated. Vaccinations have almost leveled off at around 62% with a single vaccine, 57% fully vaccinated. After leading much of the world in this area, we've fallen behind in sort of recent months, largely because new folks are not coming forward for additional vaccines, or in their case, it's not additional, it's their first dose. Mask mandates and lockdowns are returning in many locations as a last resort, really, to slow down the hospitalization and death rates. The CDC has advised mask use across the country when indoors, even for those who are fully vaccinated. So here in Oregon, we're at 210,000 cases approximately, and 2,900 deaths. So there's been a massive increase, as we just heard, in cases, especially over the last few days, in fact, and week, with over 1,650 cases a day now, making us a major hotspot at this time, even relative to other states. Hospitalizations have similarly risen proportionally, and deaths, though, are lagging, so they haven't gone up very significantly at this stage. Some of our hospital systems are close to capacity and will reach full capacity over the next few weeks without further action, thus the mask mandate that the governor reintroduced last Friday. In terms of vaccination rates, unfortunately, the lead we had versus the national average has largely disappeared due to continued slow uptake here in Oregon. And our numbers, Oregon-wide, this is similar to the national numbers now at about 62% for a single vaccine, 57% fully vaccinated. OHA, of course, has established a goal of 80%. Looking at some of our PEBB member data, so there's been about 9,000 tests with our members, 413 for antibodies. Members that have been diagnosed to date with COVID is 490, 63 had ER visits, 25 hospitalized. Members in ICU with a COVID diagnosis was 11, and fatalities we know of was 1. This is the claims data. Obviously, these numbers would have gone up a lot in the last few weeks, and we'll find that out in due course. The COVID vaccinations to date, so members with both doses, about 5,060 have had the Pfizer vaccination, 3,500 Moderna, and a small number had Johnson & Johnson. So we've got our new data that includes the alert data, and that is 68% of PEBB subscribers are fully vaccinated. Treatment costs, testing costs, $870,000 to date. Treatment costs, $1.4 million approximately. Vaccination costs, about $440,000. That data is all pandemic to date. So looking at variants and vaccinations, so the cause of this spread is the Delta variant of SARS-CoV-2. First identified December 2020, its fast spread become the most dominant strain in the US and much of the world. It's much more transmissible, causes more serious illness, and has the ability to better evade our immune systems, spreading fast, causing serious illness in those who are unvaccinated, including younger populations. So those under 12 are now getting infected at an alarming rate, something we didn't see earlier in this pandemic, with children now making up 15% of all cases. This number is rising by the day, with many young children landing in ICU. There are plans to soon introduce vaccination in children aged 5 to 12 years. The FDA a few days ago authorized the use of a third dose of either Pfizer or Moderna for those who are immunocompromised from solid organ transplantation or have an equivalent level of immunocompromise from some other causes. And that is to be given at least 28 days after the 2-dose regimen. This is likely to be extended to additional populations in due course, as we are seeing the efficacy of these vaccines reduce with time. Other countries are moving forward with this third dose for everyone. Pfizer CEO announced that its vaccine efficacy drops to around 84% after about 6 months. Obviously started in the high 90s, though independent trials are needed to actually verify this. Efficacy is the measure of likelihood of infection. In terms of serious illness, Pfizer's vaccine, all the vaccines are actually faring much better though, and they're actually remaining highly effective in that area. Vaccination is the best possible protection against the Delta variant. Although a significant percentage of fully vaccinated individuals are still getting infected, we know the vaccines are highly protective against serious illness and death. It's therefore critical to address vaccine hesitancy and to step up efforts to increase vaccination rates through interventions that resonate with specific populations. The vaccination protects individuals, society as a whole, and quite importantly, reduces the pool size within which even more serious variants will emerge. The latter would also need a more concerted effort to increase global vaccination rates from the current lows of approximately 30% fully vaccinated across the world. Given though that fully vaccinated individuals are getting Delta variant and spreading it, masks are also critical at this stage. It's important to emphasize that practical measures such as distancing, mask wearing, avoiding crowded places, hand washing, etc., will always help against coronavirus and against all other infectious diseases, and really should always be considered for the near future at least. Furthermore, there are other variants of concern, unfortunately. Alpha, beta, delta, gamma, and epsilon are all in Oregon in significant numbers. And given the ability of the virus to mutate, there is very likely now to be other variants of concern in the future once we get through Delta even. So unfortunately, this is with time looking more and more like a chronic long-term picture. That's not for certain, but we're all hoping that there's sort of something that could be 12, 18 months and largely controlled and manageable at this stage. That's not what the picture's looking like, though. We always hope that obviously things will get better. So we're doing a lot in terms of trying to address the special groups that are under-vaccinated, right from the data and the analytics to the outreach, individual clinics, even with lists, some direct calling up our case management teams. We are also working with community organizations with messaging and to name a few things on the vaccine hesitancy front. Talking points really the correct way to engage. Looked at incentives in some areas as well. And the target, we have OHA's target 80%, but as Dr. Backman said, really it's every person that's eligible. Unfortunately, that isn't a lot of children at the moment. So for now, obviously, the only defense they have is getting everybody else vaccinated. And so that is also one of the major messaging points we've now added on, that so children are sort of defenseless, and so that it's a new reason to really step up and come forward to keep kids in your community safe.
Ollie, did you have a question?
Yes, thank you. Dr. Singh, you mentioned that 68% of MOTA PEB members were fully vaccinated. Just wondering when that data was polled, if it's the most up-to-date figure that you have to work with.
Yeah, and I can speak to that. That is our most up-to-date data at the moment. I think that we refreshed that percentage just last week.
Okay, thank you.
Yeah, another question there.
Mark.
Hi, Mark.
You're on mute.
Sorry. I was looking around the websites for all of our providers, and I want to at least commend all of them that vaccination information was pretty prominent, and you didn't have to look far to find it, which is good. I mean, obviously, it's harder to convince them to do it than to just show them where to click. The thing that I was less able to find was information about getting tested. Kaiser's, the test, a button on their front page said, click here to find out where to get tested. But when I was poking around both MOTA and Providence, I had to look far and wide. Actually, I still didn't find it for Providence. I mean, I went and Googled it and found a whole bunch of places that are doing it, but it seems that it would be nice if MOTA and Providence would make it more prominent and easier to find. Click here and find out how and when and where you can get tested. Kaiser, I mean, I'm not surprised because Kaiser wants you to do it at their facility. So the others are less centralized, but it was not that easy to find information where to get tested on MOTA and Kaiser's website. So I just wanted to encourage them to maybe make that easier to find.
Yeah, great. Thanks for the feedback on that, Mark. I'll definitely take that back to our team and see how we might be able to make that more clear.
So did you want to touch on, have you seen a reduction in your workforce and throughout this? Are you seeing, and how are you addressing that?
Yeah, and I'll let Dr. Singh take that, though I will just start off, we're a little bit different than Kaiser would be, just because we don't own our providers in the same way that Kaiser would. But Dr. Singh, I don't know if you want to speak to maybe trends just in the state.
Yeah, I could talk to maybe both. Yeah, we're not obviously direct providers of sort of medical care, though we work very closely with our large network across the state. Vast majority of us being administrative, but we do have some clinical staff, mostly that can work remotely, and so generally are unaffected. We have continued high attendance. That being said, for positions that are open, particularly clinical staff, it's extremely difficult to recruit, and some of that may be related to the issues you're hearing within the provider circles, because those are the folks that we're recruiting for areas of case management and utilization management and all the other great things our clinical staff do. And some of it may just be the broader trend that all industries are facing right now, where there is massive staffing shortages that are occurring. We're hearing that across Oregon in virtually every industry, just a shortage of good, highly skilled labor, and particularly on the healthcare delivery side.
And then our other question was, what are you doing? How are you helping to reach out to those that were unvaccinated to and all populations? How are you doing? What are you doing to help reach out to those that are unvaccinated?
Yeah, so I can jump in here, Dr. Singh. First, there are a lot of different ways that we are reaching out to our members about vaccinations, and just a couple different messages on that as well. You know, one message is how to get the vaccine, and how the vaccine is at no charge to members. And then the second part of that is also on the safety of the vaccine. And so those are two messages that we convey, and we do that in several different ways. One way we do that just individually with our members. So when our more high-risk members are working with our care management programs, our advocates and case managers and care managers will help, we'll discuss with them and help direct them to be able to get their vaccine. And then we also have other modes of communication. So we do use social media. So we use social media to talk about vaccine safety. That's Facebook, LinkedIn. And we also, as noted by Mark too, we do have a lot of information on our websites, and we keep that updated. So that's information about what's covered at no member cost share. And that includes, the testing, the treatment for COVID, as well as the vaccines. And we also have a web page dedicated to just COVID. So this will talk about all things COVID really, and that's the vaccines as well, and the safety of the vaccines and the efficacy of the vaccines. We've also done some direct emails to members. One email that we did was a brochure on how the vaccine was developed and the safety of the vaccine. And and then we also have a digital newsletter that we send to just our PEBB members, and we include information on the vaccine and COVID and coverage in those articles that go out in that digital newsletter. Dr. Singh, did you have anything else to add on that topic?
Yeah, that's excellent. That covers a lot of the things we're focusing on. I mean, at this stage, it does sound like misinformation is a major issue. So really homing in on the efficacy, people saying, well, obviously you can catch Delta variant and you can spread it, therefore it's not effective, and that's not true at all. It's highly effective. But you can catch it and you can spread it. Obviously, some folks are concerned that the efficacy is dropping off slightly. Well, the efficacy of everything over time tends to decrease slightly with time. But as we heard, it's still in the high 80s, potentially 6 months on. And then there are boosters coming and so on. So it's really addressing efficacy, safety, the protection of your family, because there are now a sizable number of members of our society, children, that cannot yet get vaccinated. We're still waiting on that safety data, but unfortunately those are landing in hospital and in ICU, and that's completely new really, with this fourth wave, the Delta wave, that large numbers of teens and children are getting affected. So I think those are important messages to get across, because really the only good solution we have at the moment, hopefully there'll be other interventions in the future, but at the moment it is to go and get that first or second dose of the vaccine.
Thank you all so much. If there's no other questions, we're going to go ahead and move on to Providence. And we have Helen Noonan-Harnsberger, and then we have Jessica. I'm sorry, Jessica.
Yeah, hi.
I'll let you say your last name. Welcome.
Yeah, this is Cash with Providence, and I'll do the quick introductions. With us, we have Helen Noonan-Harnsberger, who's our Vice President of our Pharmacy Department, and also we have Jessica Nikulcha, who is a clinical analyst on our pharmacy team. I did want to make a note that Mark had mentioned that he didn't see where to get information on our vaccination testing. I did include that in the chat. So there is a link. It's coronavirus.providence.org. And there's a spot right there on our coronavirus hub page that gives you direct link access to not only our Express Care virtual to get virtual care, but also our testing facilities and how to locate testing. So it's in the chat if you need that. With that, I'll turn it over to Helen and Jessica to provide the vaccination updates.
Thank you so much, Kath. Hello, everyone. This is Jessica Nicolcha. No worries, my last name is a little tricky to pronounce, so that is very common.
Thank you for giving me grace. Thank you.
Of course, of course. And I just wanted to state that in this presentation, I will be listing off quite a few numbers, quite a few statistics. And so we do have a PowerPoint that will be shared fairly recent after this meeting, but just so you know, so you don't have to take down notes if you don't want to, but just as an update, so our PEBB population as of August 13th of this year, we now have 67.8% of PEBB members who are eligible for the vaccine, so that's ages 12 and older, that are partially or fully vaccinated. And we consider partially or fully vaccinated, again, either receiving one of the 2-dose series of Pfizer and Moderna or that 1 dose of that Johnson & Johnson vaccine. And that's around 52,910 members. Now, when we look at who out of that population has completed the vaccine series, we do see 64.3% members, or around 50,000 members. And this is an increase since last month, the information that we presented. Last month, for members who are eligible for the vaccine that were partially or fully vaccinated, that was 65.7%. Now we're at 67.8%. So although it is a small increase, it is an increase. So that is good. So 2.1% increase of that. For total membership, when looking at all members who are eligible for the vaccine, we're seeing really similar vaccination trends as for all of Oregon as well as all of the United States. So nearing in that 58 to 59% of individuals who are partially or fully vaccinated. So PEBB members are following the trend both statewide and nationally. We also are able to look into vaccination by age band as well. Just as a reminder, individuals who are ages 65 and older were eligible to receive the COVID-19 vaccine at a much sooner time point than some of the younger individuals. So we really have spent the time within these past couple of months on really encouraging those younger individuals, so ages 12 and up, to receive the vaccine. We've had various clinics at high schools, as well as we do have clinics anticipated to occur at additional high schools later on this month and in September as well. And we have seen an increase from vaccination rates. We've actually seen the biggest increase in ages 12 to 15, with a 4.4 increase since our July meeting of COVID-19 vaccination. So currently we have 51.6% of individuals ages 12 to 15 vaccinated. Ages 41 and up, we have it's 75% and higher. And so we're really working on providing more information for that younger age group. We're also seeing a really similar trend in a slight increase in vaccinations by all races. So we really want to make sure that not only are we addressing the concern for COVID-19 vaccination by age groups, but also by those communities and various races that aren't able to get the vaccine or that are at a disadvantage. So we have also provided via local community vaccination clinics, such as we have an upcoming Latinx vaccination community clinic outreach for the COVID-19 vaccine, but we've provided various opportunities to really address these populations. And we have seen an increase in all races since our previous July meeting, with the largest increase being in a 3.9% increase in vaccination in the Hispanic population. We've seen a 3.7% increase in the Native Hawaiian and Pacific Islander population, and a 3% increase in American Indian and Alaskan Native population. And for all of these populations, we're seeing the Asian population being the most vaccinated or having the highest rate of COVID vaccination at 86.6%, and all other populations being above 60%. As mentioned by MODA as well as Kaiser, we do have a concern with the Delta variant and concern for increasing COVID-19 inpatient hospital admissions. So we did take some time to look at PEBB member inpatient COVID-19 hospital admissions since July 1st of 2021, of which we have seen 17 members of PEBB with a COVID inpatient hospital admission. And we wanted to make sure that due to the Delta variant and the concerns of just the severity of the COVID-19 in this Delta variant, that we were also taking the time to look at out of these members who were vaccinated and who were unvaccinated. So out of these 17 members that did have that COVID inpatient admission, we saw 16 members were unvaccinated and 1 member was vaccinated. So again, this does emphasize the importance of the COVID-19 vaccine, that it does prevent that severe COVID-19 and hospitalization. We're also able at Providence to really look into PEBB vaccination rate by county. And we are seeing, again, the highest vaccination rates include Benton County at 89.4%, Multnomah County at 88.2%, and Lane County at 82.3%. We are also working on further encouraging vaccination rate in more rural counties, as we're seeing those are the counties with the lowest vaccination rate by the number of PEBB members, and those include Payette, Melher, and Umatilla as well. And then I'm going to pass this off to Helen to speak a little bit more into any additional outreaches and actionable items that we at Providence have done to really encourage COVID-19 vaccination rates for our unvaccinated members.
Okay, hi, good morning, it's Helen. Hey, so the thing that, as mentioned, we've been really focusing in on the rural counties to look for opportunities for vaccination there and to see what messaging will help. I can't say that we have a perfect silver lining in that regard, but you know, gentle pressure relentlessly applied in a way that is effective for that individual ultimately does get results. And I think that we are seeing that as compared to even the last time we spoke to you. Some of the specific things that we're doing, obviously, like everyone, updating our vaccination information link. And we have a major update that will occur this week too, with the information around needing a third booster for immunocompromised, and certainly preparing for what we expect will happen earlier this fall or later this fall, but not too far into the fall season, where there's likely going to be some announcements around childhood vaccination, as well as perhaps third doses for many after about 8 months. One of the things that's going in the mail this week, all of them should be in the mail by the end of the week, is that there are specific postcards going to non-vaccinated households. So if there's one or more individuals in a household, for PEBB members and for, frankly, all of our members that have not a member in a non-vaccinated status that's within an appropriate age group, there is a general postcard mailing going to those households to just really provide that messaging again about the importance of vaccination for each and every age eligible person. It's simple, it's a postcard, easy to see, easy to find on a kitchen table after the mail comes in, and just that gentle reminder around the importance from a multi-generational perspective for everyone in that household to be vaccinated. In addition, we are doing a variety of blogs and posts that are going to be available to members in various social media channels regarding vaccination, especially as we get close to the flu vaccine season, as well as the vaccination timeframes for students going back into college, elementary school, high school, and just kind of in that back to school timeframe. At that, that is one of the motivating factors that's occurring. And there is more of a movement now to create an atmosphere that within workplaces to assure that workplaces remain safe, and more employers are embracing some type of approach, either requiring vaccination or requiring vaccination, and if there's vaccination, doing weekly testing in certain environments. Some of that's mandated by some of the state's requirements. Some of that is just being taken upon some of the employer groups. So those conversations are occurring certainly in many locations and not just within the PEB environment. So we're focusing on, employees and the family being flexible. We're open to helping PEB with any flu events. We've certainly reached out to Ollie on that, as well as the folks at goodflushot.com. We're happy to partner with other carriers and happy to do whatever we need to do going into this particular flu season, because I think it's an opportunity to do both flu vaccine as well as that first or second dose for those who have been unvaccinated, and perhaps for those who are immunocompromised at this state, we can certainly assure the third dose is given. So I think there's a lot of really important work that we still need to be doing in each and every community. Providence's approach has been to work directly with the public health agencies and entities in those communities and various community partners. And we can, will, and have done that in some of our outlying communities as well, and are happy to do that in any community. I'm most interested, as I mentioned to the group last time, in really seeing what we can do in some of our most rural communities, because the vaccinations, and we'll send you this data, I mean, in some of the counties is as low as 40%. I think I saw one county at 35%. That's very, very low. That's, that's really, I'm sure reaching out to those particular public health officials in those counties, maybe there's some ways that we can do direct partnerships with them, and really in support of not just the PEB membership, but maybe the PEB membership can help lead the way in those communities to spur others to get vaccination. So with that, I think only one other slide I wanted to, that I'm talking from slides, which we're going to send to you, but really, as the FDA and CDC and ACIP authorize additional vaccine doses for individuals, we're staying really up to date with that and making sure that we're making adjustments to assure access to all of the members now who are immunocompromised. And as you know, CDC was very, what I would call very general in their definition of immunocompromised. So it's very possible that it's going to be a broad definition. And I think that given the fact it's likely a third dose will be recommended sometime maybe later this year. Certainly, I don't know the exact date, but certainly everything I'm reading tells me it'll be very soon. So soon to me means within the next 3 to 4 months, if not sooner. And so I think, we really need to start gearing up people to be ready for a third vaccine, because it is the best way, as we've all said, to keep people safe and out of the hospital. I know in our Providence hospitals, we have about 105, perhaps 110 patients today. The number's been going up very, very quickly the last 2 weeks. It certainly is contributing to, burnout and issues with staffing for nurses and other key staff in those areas. I think that, we're expecting, critical staffing needs in our hospitals over the next few weeks, and every attention has been placed on that by our hospital leadership. And And I think that we're in a good position right now. I know that at least one of our ICUs had an increase in beds during 2020, intentionally added a number of beds to our ICU facilities. So that's very helpful, especially in this pandemic. At this time, the COVID situation is not causing cancellations of surgeries or anything like that, but there are a few delays, maybe a week delay, or two for elective surgery. So it's just important to know that every effort is being made to make sure patients get access to the care they need, and that we provide that care safely. And I have great trust in our hospital system. As you know, Medford is particularly hit hard. Both of the hospitals in Medford and then the hospitals in Josephine County are particularly experiencing increases in hospital rates due to COVID. So there are certainly extra efforts in that part of the state for sure. So with that, I'll close, and just if I didn't cover a question adequately, please let me know and I'll be glad to do that.
Thank you so much, Helen. Okay, so if we don't have any follow-up questions, I think they were able to address. Ali would like to just insert just some the vaccine incentive that was offered. He'd like to give us an update.
Yeah, thanks, Kimberly. It looked like Jeremy and Sean, did you guys have a couple follow-up questions before I get started?
Oh, sorry.
Oh, that's okay. Just popped up.
No problem. Sean, you want to go first?
So, follow-up question about the staffing retention issue, and the part of it that is particularly connected to, the plans. I think, this idea of incentive payment, or like signing bonuses, retention bonuses, that sort of thing, just given the bidding war, just getting new nurses and so on. I'm curious if that has come up, if that's like a major part of the conversation right now. We're just not there. If that's starting to be built into, the finances. Just curious about that aspect of it, the kind of financial incentives for employee hiring and retention.
Well, I would think I'm not the expert to reply on that on behalf of our health system for sure. But I do know that the use of hiring and retention types of bonuses are in place and have been in place for many years in our organization. They are prudent and within within a market, what's a market need. And I think one of the first things that I know is being discussed is, the exempt caregivers throughout our organization, those of us who are licensed as well, such as nurses and pharmacists, providing some relief to the frontline workers. Certainly someone like myself, it's been years since I've practiced in an ICU. I would never be in the ICU, but I can certainly help in another part of the pharmacy department that could free up another caregiver to go to the ICU or one of the floors. So I think there are other avenues on the surge basis that are being looked at as well, but certainly retention of caregivers and retention and recruitment is a key focus, and every leader in Providence is focused on that, not just in Oregon, but in every state. So that's probably as specific as I can get without asking for one of my colleagues on the health system side to be present.
And then Jeremy.
Yeah, thanks. I guess just an overarching comment, not really a question for folks with Providence. I appreciate the sentiment that getting to that final hard to reach population, folks who are resistant to, to getting the vaccine is a delicate balance. I guess I appreciate Dr. Bachman's statement that the end goal is 100%, but I think I think we all know that in order to reach any type of target, you actually need to have some smaller targets that you're aiming for, that you're really directing your resources and strategies towards. And so I feel like was missing from all the presentations today was how are you going to get from 70 to 80 and then 80 to 85 and 85 to 90 or whatever the right targets are. But I feel like to just say, well, we got to 70, now we're trying to get to 100 is I think not specific enough in order to be able to really have very strategic efforts to try to get at the remaining population. So I guess I would really like to see from our planned partners how they're going to really specifically try to get from 70% to the next whatever the next reasonable step is. That's 80%, 85%, 90%. Because I'd really like to see efforts that are targeted at a goal and not just broadly we want to do education, broadly we want to make sure that there's research. And again, I realize that there's probably not one set of strategies, that depending on where folks are at, what information they trust and rely on. But especially when we're thinking about closing inequities and disparities in these numbers based on population by race and ethnicity, if we don't set a target for actually how we're going to close those gaps, I don't know how we expect to do that over the next several weeks or months. So I would really appreciate it if each of the plans would really come back with a strategy for how we're going to continue to close the gap on the 30%, and rely, Kimberly and Ollie, on you on what's reasonable. But that would be, if I could have my druthers, we'd be moving in that direction.
Thank you. I think that that's a good opportunity for them to think about that for their next month, for when they give us updates. And we'll have Ollie or somebody follow up with exactly what the question needs to look like, the present on. And then, as we can see, because we do have follow-up questions, 10 minutes per provider is not enough. So we'll look at that also, so that we're not delaying our other speakers. So thank you all very much for presenting. And now we'll go on to Ali, and then we'll look at more specifics next meeting to address Jeremy's questions to the providers.
Thanks, Kimberly, and thanks for those questions, Jeremy and Sean. I think this isn't just PEB's top priority right now. It's our states, and while we are over time, I just wanted to give a quick update on our vaccine incentive program and our efforts to bring worksite vaccination clinics to PEB members, along with our flu shot clinics this fall that Helen briefly alluded to. Right now, we have, as of yesterday, 28,061 attestations for a $100 incentive, of which 547 submitted with a religious or medical exemption, which is about 1.7%. There does not appear to be a significant uptick in July as far as vaccinations, although the vaccination numbers for PEB are higher in July than OEB. I think that was the first month that happened, but not significantly. I think it was 104. OEB actually is about at 80% versus PEB at 72.4%. So currently we have approximately 10 to 11,000 subscribers who are vaccinated but have not yet submitted for an incentive. The governor recently announced a vaccination requirement for state employees as a term of employment. There's a deadline in October, or based on FDA approval of the vaccines. Right now, we're having conversations with our flu shot clinic vendor and have confirmed that they are able to provide COVID vaccines at work sites. So we are conferring with staff at Public Health Division about the logistics and expect to have firmer plans very soon. And I think as convenient as we can make it for folks to get those vaccines, even booster shots as well as flu shots, especially in those lower vaccine completion areas. the more likely we are to increase the numbers in those areas. So I guess I would conclude with the incentive program was really focused on doing whatever we can to get more folks vaccinated. I think there has potentially been an uptick, not a significant one, but I think if anything, we've seen maybe the Delta variant had an even bigger incentive for people to get in there and get that done. So there's no questions. That's all I had.
Ollie, I had a quick question about the data. Do you have information that's down to, well, how detailed is the information? Is it down to the worksite level or the county level in terms of vaccination rates? So you have a sense of where to target the clinics.
We can get that. The data is always a little sketchy just because there are some lag issues, but I think it's gotten better just in the last month. So we were able to get it by school district for OWEB. So I can work on that and bring it to the next meeting or even before that if you'd like it sooner.
Thanks, Holly. I'm just wondering about it in terms of the targeting efforts, in terms of where to focus and have the clinics.
Yeah, I think PEBB has more rural employees than OWEB. I think that's one of the real challenges with PEBB. But certainly we can at least compare that with the overall state data by county and by region, really, and get those areas get out there a little bit more and do what we can to get those numbers up.
Ollie, I was wondering when they were talking, some of those counties, the rural counties, I was wondering if the fact that there's some prisons in some of those counties helped raise their numbers. If there hadn't been prisons there, I wonder if those would have had even more, because some of those prisons have, anywhere from 500 to 1,000 employees. So that's quite a few individuals getting vaccinated. So, yeah. So
you've really been, or I should say, you've been really on top of getting back on-site vaccine clinics at the prisons, and we've been pretty impressed as we've reached out to them to do what we can to help them.
Thank you. Well, we're battling it. That's for sure. We're battling it. Okay, so we, Nick, have totally messed with the agenda, and we're now at 10:33, and we're all yours. So you're going to give us RBC update, and we apologize for running behind, but I think it was also very good dialogue that was happening between us and the providers. So good morning.
Good morning. Yeah, I could tell nobody wants to hear about risk-based capital reporting. We're more ingrained with the vaccination rates, and rightfully so. One thing I will note, so Ollie mentioned a little bit about getting data vaccination rates by county, maybe by agency. That's something we are looking at for PEBB, and actually MOTA has already supplied us with that level of data. We're waiting on Kaiser and Providence. Both of Kaiser had to send it actually out to their national team to look at agency data. Providence is also researching that internally to see what information they can provide. So that's something we are exploring to see if there's varying vaccination rates by agency. We know there likely are. So maybe that will help with the targeting as well. Rose, would you like me to share my screen?
Yeah, go ahead. I'll get off, Nick.
Okay, perfect. Okay. All right, so that should be up for everyone. Okay, so luckily I know I have Brian hot on my heels, so I don't want to tick off Brian and his scheduling. So I'll try to work through this as quickly as I can. Luckily, this is a relatively short report with what I consider relatively good news as far as financial position for PEBB. So what is risk-based capital? So this is a report that we typically look at a few times a year. It's a method of measuring minimum amount of capital for reporting entities. So it was developed by the National Association of Insurance Commissioners, And the main application is within insurance companies to make sure insurance companies have enough capital to be solvent, to protect against insolvency or insolvency or liquidity issues. We look at it for PEBB because PEBB basically functions as an insurance company, just given the amount of self-funding we have across the medical plans, the dental plans, and the vision plans. And the amount of underwriting risk that we have in any given time. So if we, think back to 6 months ago when we were developing the premium rates and the composite rates for the 2022 plan year, we used data from 2020. And so what that does is, just given the lag time there, it creates basically 2 years worth of risk that PEBB has, for lack of a better term, where we won't be able to adjust funding rates until we receive the data. And so if those funding rates are significantly off from where, we projected them to be, that's what creates the risk of, solvency or liquidity or whatnot. So that's why we look at RBC. It's basically looking at the stabilization fund versus where the targets should be. Before we get into the actual results, I do want to spend a few minutes talking about some of the underlying assumptions, the methodology that we use when we're thinking about RBC and the various projections and funding levels that we use. So on the left-hand side there, that claims and enrollment. So when we look at risk-based capital, what we try to do is update with the latest claims data and the latest census data. So the claims and census are both using June 2021. So what we've done basically, now that we're looking at this in August, we have 6 more months of data that we didn't have when we were setting, funding and projection rates for the 2022 plan year back during the renewal time period. So we have 6 more months of data that we didn't have in prior board meetings. In that teal left column there, the one labeled market trend rates. In prior reports, we refer to these as Mercer trend rates, but in reality, they're a combination of what we see at Mercer from other commercial clients, from our data warehousing solution, which PEBB is obviously a part of, and then honestly, what we get from carriers and feedback that we see from carriers on what they're seeing as far as medical trends and pharmacy trends in the marketplace. One thing that I've done for this RBC report and compared to previous reports is actually we've lowered the long-term trend rate. So 2023 and 2024 are sort of those years that we look at that are longer-term time horizons. What we've done for this report is actually lower that long-term trend from 6.5% to 6%. What we typically do is look at PEBB's utilization by the various service categories. So inpatient, outpatient, professional, medical drugs, pharmacy drugs, all of the various service categories that we looked at last month in the utilization report. What we do is try to forecast those individual service categories by certain trend rates. So there's basically 3 primary reasons why we ultimately decided to lower the trend rate from 6.5% to 6%. It doesn't seem like a lot, but when you're talking about compound interest, in future years, 6.5 to 6 really does make a little bit of a difference there. We know that inpatient costs and outpatient costs, facility costs, that is, are capped. They're tied to Medicare, right? So they're at 200%. What that does is it created a one-time savings, a big savings for the 2020 plan year. But we also know that Medicare and CMS inflation tends to trend lower than commercial trend rates. So over the past 5 years or so, Medicare reimbursements have generally trended anywhere from 1.5% to 3% per year. Given PEBB's claims data, we know that about 30% of PEBB's costs flow through inpatient and outpatient facility. So you can make a reasonable assumption that given the majority of those costs are at the capped hospitals, we know that likely there's some level of trend control within the facility costs for inpatient and outpatient. Another component that we looked at is for the upcoming plan year, a lot of the work that the Innovation Work Group has done, Margaret and my colleagues have put in place performance guarantees with our carrier partners to tie the costs to 3.4%. So what we're going to be looking at for 2022 and beyond is ensuring that claims costs don't increase by more than 3.4%. And those performance guarantees are across all three of the carriers. Now, there's going to be some, exceptions, right? So there's going to be some risk adjustment involved. There's going to be adjustments for high cost claimants. So it's not exactly like taking, 2023 divided by 2022, and that's 3.4%. It's going to have a little bit of adjustment mechanism within there. But the fact that we have these new performance guarantees in place, that did weigh on our minds when we were thinking about long-term trend rates. And then finally, we did think about what's going on in Oregon on a whole. And I know Jeremy's on this call, but a lot of work that's being done on the Oregon cost growth target as part of the Healthcare Cost Containment Committee. Currently, that program is trying to raise awareness for the target in provider groups, in healthcare systems and whatnot. So we know there are broader initiatives taking place within Oregon as a whole that will certainly have a benefit for PEBB and OEB and all the commercial stakeholders that we have within the state. And so we think there's ultimately going to be some benefit and teeth to that program that will allow us to foresee some trend reduction in future years. So anyways, that was sort of all of the thinking behind as we were going through, what future trend rates to use for, years out into the future. I'll pause there before I get to the other boxes. Any questions on that?
Yeah, I have a question. It's a comment that we talked about a little bit before, and I just kind of want to broach it here, not really for a specific response, but more of something to just kind of set the stage for our conversation the rest of the day. One of the tricky things for me over these years, learning, the medical field and price in all this is the concept in economics of price versus volume. Right. And in a lot of fields, those two things are laser clear. Like there's a price for something or a service, and then there's how much of it you're going to do. In the medical field, in these discussions, when we're talking about costs, sometimes we mash those two concepts together, and that gets confusing. Sometimes when we say cost, we mean price. And sometimes when we say cost, we mean price volume. And it gets fuzzy because the 3.4% cap on us is the fuzzy price volume. Like it's agnostic. It doesn't care whether that was because you had lower costs, but you had higher volume, or you just had lower volume, even though there were higher prices. It doesn't care. But I care. So what I am concerned about is that we are now heading in, this is my main point here. We're heading into the fourth wave. We're not heading in. We are now in the fourth wave. We will likely have, I am predicting based on absolutely nothing, not an expert, but I predict that in the fall, we will have something resembling a fifth wave due to school going back and so on. That's just me. Personal opinion, not on behalf of OHA. Thus, there right this minute, there's already reductions in volume because the hospitals are already right now shutting down electives. They're just like, nope, no room. Okay. So what I am concerned about and what I am hoping that you have your eye on and that you will keep us informed about is that while volume is down, costs, meaning price volume, looks like it's down. It is down. Price volume's down largely because volume's down. But the price side of it's up because the industry is essentially trying to respond to make up for lost revenue and cover other costs, so that when volume comes back, there's a like a liftoff, like a missile, because while volume was down, prices went up, like way up. But it was kind of like below the radar, so to speak, because price volume was down and 3.4% was met. And so I'm just bringing that forward, that we are keeping our eye on the price side while we are talking. I am expecting price volume to be quite low again this year, like another kind of repeat of 2020 essentially, which will temporarily look good on the bottom line. But when we come out of this, we could have a very rude awakening if we were not careful about containing price. So that was it.
I completely agree. And that's something that I know is on your radar. I know it's on Jeremy's radar as well, you know, PEB in general. When we looked at, you know, last month's utilization report, unit prices. So when we talk about unit prices, that's always the issue. You know, and whether that's, you know, when we talk about unit prices, again, it's a mixture of different things, but we're talking about not only provider reimbursement levels, but also mix of services as well, severity of those services. And that's the one thing, Sean, coming out of the pandemic that we're all sort of aware of too, is, well, okay, there's lack of preventive care happening, there's lack of screening happening. So is not only the reimbursement levels are providers looking to charge more, but also is the severity of what those cases could be, is that going to increase as well? Are we all of a sudden going to catch cancer cases months down the road where we could have had, you know, early detection and screening for those? So that's something that yeah, is absolutely on our radar. One thing, and you're part of the IWG, so you're well aware of what's going on with that, but part of what's coming out in 2022 also that our carrier partners are going to be helping us with is transparency reporting. And that's not only at the federal level. So we've probably all heard about the federal requirements for transparency. That will provide a great deal of insight into negotiated prices for various services, where we can monitor where, you know, what services are increasing in price, what are, you know, decreasing and whatnot. But also your carriers are also agreeing to provide different additional reporting for PEB and OEB as well, basically, you know, looking at percent of Medicare, you know, what services are being charged in that realm. So there are some additional programs being put in place effective 1/1 of this year that we're going to be reporting out on to monitor that type of situation. Okay. The other two on here, so we do take into account surcharges from employees, so spousal surcharges, tobacco surcharges, and then the HEM payments. So together, surcharges are about $4.5 to $5 million between the two different surcharges, and then HEM payments are about $10 million. So HEM is a net increase in cost, basically, because those payments are going to employees. And then surcharges are sort of a revenue stream, essentially, where it does count for, you know, reduction in cost, offsets in cost. For the projections, so what we've done for 2020, 21, and 22, so the, you know, three, you know, plan years around where we are talking today, we've done actual projections for those, again, using data through June 2021. And then, like I said, as we get into the forecasted future years, 23 and 24, that's where the market trend rates take into, you know, come in, and you know, the 3.4%, depending on the scenario. Okay, so the four key takeaways. So for 2020, and Sean, I think this is exactly what you're talking about, the price volume equation, right? So price volume is essentially paid claims, whatever PEB is paying, whether that's a reduction in volume that's causing that, which is certainly the case for this past year, and continues to actually be the case into 2021, or a reduction in prices. It's typically always just a reduction in utilization. So for that first, you know, the top key point there, The fund balance in 2020 actually grew about $118 million as funding exceeded actual costs in 2020. The balance actually closed at around $349 million, which is net of liabilities. So when we think about the liabilities that PEBB has, it's basically the incurred but not paid claims or incurred but not reported claims. So the IBNR liabilities. So the fund balance is basically our starting point, $349 million. 2021, we actually have projected costs to be slightly lower than anticipated. So again, the fourth wave that we're in right now, but even prior to this fourth wave, in the 6 months leading up to where we are now, claims really never have not come back yet to pre-pandemic levels. And I think that's, again, a question of, we know there was some level, or there is some level of waste in the system with unnecessary procedures, testing, whatnot. So is that, the new normal, so to speak, as far as, what level of claims, or will it rebound? Our guess is that it will likely rebound as the pandemic wanes. But again, these waves, this fourth wave, and I think a lot of folks would agree with Sean's point about there possibly could be a fifth wave in the fall time as kids return to school and whatnot, and flu season ramps up once again. But through 2021, we do project a surplus. However, we had a $63 million transfer from the stabilization fund, and I believe that happened in May of this year. And so it actually resulted in what we're projecting, at least, a slight decrease in the fund balance of $46 million from the end of 2021. But we would have had a surplus if that transfer did not take place. For 2022, projected costs continue to be lower than funding. So we are projecting a slight surplus for 2022 of $9.8 million. Even a surplus after we account for the penalty. So we have the transfer of $63 million happening this year. Historically, we've been taxed on that by about a 10% tax penalty on that, which gets paid in the following plan year. So we're accounting for that transfer penalty of $6.3 million. So we still have a small surplus we're working with in 2022. And then by the 2023 plan year, that's when, the costs and funding lines cross, so to speak, and that's where costs start exceeding funding and the surplus begins to diminish, is what we're projecting. So here's the fund balance as of December 31st, 2020. So you can see that this is the $349 million reserve that I mentioned on the previous slide. The total fund balance here is actually closer to $405 million. But like I said, we account for the IBNRs for each of your self-funded plans, and we also account for some of the operations expenses and the FSA dependent care expenses that are held to make sure we're looking at true what is the net stabilization fund. You can see actually the target we had for this year for 2020 was $187 million. So the net difference is significant, right? So we're above our target by about $161 million or so by the end of 2020. Okay, so let's look at where we're going now from 2021 through 2024. And this is using the market trend rates. So when we get out to, the 2023 and 2024 plan year, that's where we're projecting the cost to increase at 6% per year instead of the 6.5% that I was referencing earlier. What we do on this, and just to orient folks to what the graph actually is pointing at, so this blue bar here for each year is essentially the target. So the low target versus the high target, and then this teal line going through the blue bars, that's sort of the median funding level. And so when we talk about, this statement down here is 4% above target, that's just referring to this purple line being 4% essentially above the teal line. So the teal line is really the target, but we do know there's a range. So depending on whether PEBB wants to be more conservative or more aggressive with the reserve target, that's where that blue stacked bar comes into play. And then up here, the purple line is the ending fund balance. So that's where, at the end of 2021, we're projecting an ending fund balance of about 302 million. That's that, what is it, 48 million or so decrease that I mentioned earlier, and mostly due to the transfer of that 63 million. So we would have had a surplus, or we would have project to have a surplus for 2021 in absence of that $63 million transfer. The reserve target, what we look at is essentially a reprojected. So it basically takes into account, what the expected claims costs for each, upcoming plan year are, and that's how the NAIC, the risk-based capital formulas work. So it looks at, what your projected claims cost is. It divides it into various buckets, and then it, what we can do is calculate the reserve target for, your medical plans, adding in your dental plans and your vision plans. What we do, so when we think about what funding is, so funding is what, agencies are paying us for the premium rates. So those, when we look at RBC, don't change from when we set them at renewal time. We don't reproject, funding rates, for instance. Like those are the set renewal rates that we develop, 6 months ago for the upcoming plan year. But what does change, and what we experience every year with sort of the shifting of enrollment between the plans, is the funding rate only varies by the enrollment in a given plan. So if there's more people shifting out of statewide into choice, for instance, that actually lowers the funding rate a little bit because the actual accrual rates are lower for the choice plan than for the statewide plan, for instance. So the funding rate only shifts by the enrollment. The projected costs, on the other hand, that's where we use updated claims data. So, the funding rate still stays relatively stable, but for the cost, that's where we reproject, what do we actually think now that we are 6 months into 2021, what do we actually think is going to happen for the remainder of the year, or into 2022, for instance. So that's where we do the claims reprojection is actually on the cost side of things, whereas funding is simply just looking at where the enrollment is now versus where it was, at the renewal time period. So like I said, 2023 and 2024, what we've done is trend five for medical and 10 per pharmacy, which, like I said, equates to about 6% per year. So it's right around that 6% that I mentioned on the opening slide there. Any questions on this? Okay, so only a few slides left. This looks at the PEPM, so the per employee per month cost versus funding. So the blue bar within each year represents PEBB's costs, where we're projecting PEBB's cost to be. The green bar represents PEBB's funding level. For reference, so one thing that's pretty stark here is in 2020. This was an 8%, this cost was about an 8% decrease from the per employee per month cost we saw in 2019. Likewise, in 2021, that's a 12%, increase over this depressed costs in 2020. So for everyone's reference, in 2019, PEBB's net cost of this blue bar was $1,521 per employee per month. So when you think about 2021 in relation to 2019, this blue bar is actually only 3.1% higher than 2019, and that makes sense considering in 2021, this time last year, when we were forecasting our costs for the upcoming plan year, we actually we didn't even have pandemic information, so we were using 2019 data to forecast into 2021. So that made sense from a cost and funding perspective. And as we get into 2022 and the plan years, so you can see that in 2022 we're still forecasting costs to be lower than funding, and then the equation shifts once we get to 2023 and beyond. We assume in these future years that the board elects to fund at the 3.4%. So obviously that's our cap. This is always the conversation we have related to whether we have a funding assessment in the upcoming plan year is basically whether, to continue to build up the stabilization fund. In the 2021 year, so this year that we're in right now, we actually have a negative funding assessment being applied to the rates. So if you recall, we had forecasted the composite rate last year to be increasing 1.6%. We bought that down to 0.8%. So we basically split the difference between 1.6 and 0. So we bought it down to 0.8% funding increase. That proved fine, just because given the experience we've had for the first 6 months of this plan year, experiences continued to be lower than where we were expecting. So that has proved to be an okay decision as far as not any repercussions, so to speak, from a funding perspective, a stabilization fund perspective.
Nick, Jeremy has a question.
Oh, hey, Jeremy.
Hey, thanks, Nick. So I made this comment a couple of years ago around a similar slide that was, it's actually a slide you have in here that shows I think it's a slide that shows it's kind of a line chart that shows, I think, the burning platform of reserves, but I think this one's actually better. I mean, to me, I realize this is all based off of assumptions and assuming that we're going to trend at the same national market trend, which I don't think that we should assume that personally. I think it's fine for kind of planning purposes, but I think we should be assuming we're going to beat that trend. But I think this shows our burning platform. I mean, this shows that we've got, 2 more years to basically get some significant, delivery system changes in place through value-based payment, through cost growth target accountability. Otherwise we can see what starts to happen. And so I just think this should be front and center on our minds in each of our board conversations. I mean, I just feel like this should be almost up all the time, going, what are we talking about and how does it relate to this burning platform? So just want to make that comment.
Yeah, thanks, Jeremy. Yeah, and certainly in the context of the burning platform, if we look at this slide, it's not only, it should give us, at least how we've used it in the past as well. It's like, okay, well, if we think about the 3.4% mandate, we cannot increase funding by more than 3.4%. So what the delta is between blue and green there is really, if we don't have reforms on the healthcare side of things, it's the benefit plan changes that we need to make as well. So increasing deductibles, increase out-of-pocket maximums. It's that cost shifting that would have to be done absent other strategies, which I know PEBB and OEB and OHA, we're all hands on deck to look at those other strategies. But that is, kind of the, to your point, the burning platform. Absent those strategies, it's cost shifting because we're mandated to be at the 3.4%. Okay. All right. Last slide. And okay. Yes, I try to be quick, but Brian's probably patiently waiting for me. So this is the fund balance, assuming we have a cost growth of 3.4%. This is sort of the other extreme, right? So market trend rates at 6%. So maybe what if we held the cost growth to 3.4%? So obviously, if we do that, you can see the purple line never really even gets close to the teal line. So the reserve target remains at this lower threshold because we're lowering costs. Likewise, the fund balance, the ending fund balance for each of the subsequent plan years remains and continues to grow higher. So these 2021 and 2022, if you refer to the previous 2 slides, these actually don't change. We forecast those, and 2022 is just a reprojection of what we did 6 months ago. But for 2023 and 2024, that's where we changed the trend rates for this purple line at least, to be 3.4% instead of that 6%. So it's likely, PEBB certainly does trend better than market, and we've shown that in the past, however many years. It's likely there's going to be some convergence, right, of what we showed on the previous slide of 6% versus this 3.4%. It's probably going to be somewhere in the middle, but the 6% is where, our best guess is as far as the challenges that are present in the future plan years. So with that, that's it. So we have a few slides in the appendix that provide some details on the calculations and whatnot, but I will leave that to your own reading. And I see Kate has her hand raised.
Yes.
Thank you. We can't talk risk-based capital without me having a question, so Holly knows that about me. Sorry, Nick. Really quick, you're using the same number of employees and projecting it out, correct? Yep. Now, that's not going to be true. The state is adding a significant number of employees based on the most recent budget. I think what that does, though, is because it looks like what we'll do is we'll probably have in 22-23, plan years 22-23, the differences between the blue and green line, if I go back to your slide 7, are going to get bigger because we'll have more employees. And then, so I'm kind of curious, your initial thoughts on if we add a significant number of employees, which I think every manager in state government is trying to figure out how do we hire and onboard in the next year or two. What does that look like, and how does that then also affect your trending when we're talking?
So actually slide 7 would likely not have much of an effect because that's looking at per employee per month costs. Yeah. But what it will do, Kate, to your point, is if we go back to slide 6, the absolute values. So if we're multiplying by more people, those per employee per month costs and funding levels, if we're multiplying by more people, that increases the magnitude of, the surplus, for instance, in 2022. Is it 9.3 million? Is it 10.5 million? So the gap, so either the surplus or the deficit will get magnified. Now, what I will say, based on our experience, new hires, generally speaking, cost less than existing employees. Generally speaking, new hires are a little bit younger. New hires also sometimes come from other places of employment where they have received all of their medical care, maybe in the last 12 months, transitioning over to PEBB benefits. Maybe they don't need as many procedures right off the bat in that first year. So what we find actually is new hires actually cost a little bit less. So what that could actually happen is it could help the bottom line from a cost versus funding perspective.
Great question.
Just something to keep an eye on as we're dealing with new employees. And I know I have to agree with what both Jeremy and Sean were talking about earlier on keeping an eye on the cost and the need as we are seeing this inversion.
Yep. Okay, so we're going to do a little agenda rearranging. We are going to take, I'm going to honor the break. So we're going to take a 10-minute break now. So from 11:08 to 11:18. And then we're going to have Dr. Paul Geiger from Providence report. And then we're going to have Brian. I apologize, Brian, but I don't know if Doc has an appointment after us. So we're going to let Doc go first. And we'll go from there. And hopefully that's good with everybody. So let's take a 10-minute break. Stand up, stretch your bones, and we'll see you guys back in 10. All right, it's 11:18. Let's go ahead and get started again. Thank you all. Welcome back from the break. We now have Dr. Paul Geiger from Providence to report to us on transition to in-house administration of behavioral health. Welcome, Doctor.
Great, thank you. Can you hear me okay?
We can.
Okay, super. And I'll be kind of co-presenting with my partner from Beacon, Dustin Howard, who'll be sharing some information about care management and some other factors. So happy to be here today. Appreciate the opportunity to share our story. If we go to the first slide. My name is Paul Geiger. I'm a psychiatrist by training, long-term Providence employee. I've been with Providence for about 16 years. Previously was the regional director in Oregon for behavioral health, and joined the health plan in October because of this really exciting opportunity. As you know, we for many years had carved out behavioral health to Optum for, I think, several decades. And we made the decision to bring that back in-house for the majority of our members. And go ahead to the next slide. And, really many reasons for this. But I think number one, we really prided ourselves on being a regional plan, with local control and relationships. And we also really prided ourselves on our care management team. And so we really believe that we needed to integrate, nationally, systems are moving towards whole person care. Our delivery system colleagues at Providence Medical Group, for example, now has a psychologist embedded, I think, in every primary care clinic in the state. And so we just felt that it made sense to have that synergy to improve outcomes and hopefully lower costs. As you know, untreated mental health conditions can raise medical costs. So the model really is I think unique in the sense that we're partnering with Beacon, but it is a partnership. It's not a carve out. It's kind of a co-located staff augmentation model where we've maintained the risk, and it's been working really, really, really well. Next slide. Really the goal here, this is kind of our, the goal of this integration is to create, improve access. And these are really kind of the goals of our program here. Care equity, quality care, being really member-centric, which is access really does address, and then doing so in a cost-effective manner. New slide. So, with that in mind, I was going to introduce Dustin Howard. He's kind of my main partner with Beacon. I'll let him introduce himself, and he's going to run through how we've slotted and arranged our care management program. Dustin?
All right. Thank you, Dr. Geiger, and hello, everyone. Good morning. So I'm Dustin Howard. I'm a licensed mental health counselor. I'm the director of our behavioral health services, overseeing utilization management, case management, and pretty much all of the care management functions around behavioral health. So I'm going to talk a little bit about what that looks like in this current partnership. And we can go to the next slide. So as Dr. Geiger had talked about, the model relationship that we have with Providence Health Plan is quite unique in that we're not utilizing our typical carve-out model where behavioral health is being managed separate from other health plan operations. Instead, what we've done is we've fully integrated ourselves in with Providence Health Plan and are fully integrated with their care management operations. So medical case management, customer service, all of those things. We work within the same system, same phone line, same everything. So it's a very seamless experience for members, which I think is a big strength of the model that we have now, is the increased collaboration just across the different functional areas that we can now have to make sure that we're managing members appropriately around their behavioral health, but really their whole healthcare. So I wanted to talk a little bit about what our program structure looks like, and I'm confident that you all are quite familiar with what these roles are. But with our case management roles, these are our member-facing roles that work one-on-one telephonically with members that have behavioral health needs. We do have our program segmented so that we're able to capture members that have what we would call very light or basic behavioral health needs, and that might be needing assistance getting coordinated to a behavioral health provider in their area, which we all know is a big challenge right now, all the way up to working with those members that have demonstrated more acute behavioral health needs, multiple admissions into higher levels of care, ER visits, and so on, and everything in between. And so we have, as you can see here, and I won't read through what each of these roles do, we have our intensive case managers that are doing more of that high acuity work with members who are high cost, high utilizers and have more pronounced needs, both with their behavioral health, but also with social determinants of health. We have our intermediate case managers, which some of those do sit under the Providence HR umbrella. Some of those sit under the Beacon HR umbrella. And those work with those members that still have clinical needs, but really aren't quite high acuity, but do require some ongoing management. But then we also have our behavioral health care navigators that are oftentimes the first point of contact for a member when they call into customer service. And we're going to talk a little bit about what these navigators do. But they're the ones who will talk with a member who's needing to get connected in with behavioral health care, and they will actually begin doing a lot of that legwork for the member. So contacting providers in the community who could be a good fit, so we can locate available appointments, help the member get those appointments scheduled, try to get them connected in with virtual care if that's what's needed. Really, whatever the member is hoping to get connected in with, that navigator will kind of help to take the burden off the member of doing that and present them with the viable options available to them. We're also doing follow-up with members who have discharged from an inpatient unit or have visited an emergency room for a primary behavioral health reason. And the purpose of that role is to ensure that individuals discharging have an adequate discharge plan and are working to get those folks connected in with a behavioral health appointment within 7 days of that discharge. And if we can't do that, at least within 30 days of the discharge. And so they are part of that navigation wing, but are focused on those that are discharging from higher levels of care. And then our intensive case management care coordinators are there to support our case management team. So as we are researching resources and trying to gather all of that into something meaningful for the member, they can help gather all that information and get that ready to go for the member. So next slide. And then we have our utilization management program, which is pretty cut and dry with what we do. So we do manage inpatient behavioral health, residential treatment, partial hospitalization, intensive outpatient. And we see this role being more than just applying the medical necessity criteria, but we are trying to work with the facilities to try and think longitudinally about what a particular member might need, so that we're not, one, coming up on the day of discharge without a discharge plan, but also trying to strategize with the providers on what is this person going to need long-term? How do we start planning for that now? And making sure that those transitions of care between levels of care go smoothly, and all of those would be managed by the same clinician. We have a specialty ABA team that are licensed behavioral analysts that field those ABA requests from ABA providers and also are able to help coordinate care for individuals that are needing additional services around autism that are needed. And then we have our administrative roles, which I won't get too much into, but also work with back-end claims, looking to make sure that providers are being paid according to contract and addressing any type of claim or billing issue that might come up, or a claim concern that we might identify coming from providers. And so they'll start the process of doing some further investigation on those. So what I'd like to highlight here, now that we've talked a little bit about what these individual roles are, is how this really all fits together into a meaningful picture. And so the program that we have sees member management as combining all of these functions into one team that is going to strategize together to make sure that we're taking care of members the best way that we can. And one way that we do that is We do have regular integrated clinical rounds multiple times per week. That includes both of our case managers and our utilization management team. The philosophy behind doing it this way is one, as we are making coverage determinations for different levels of care, I believe it's important that we're taking into consideration the unique circumstances that surround a member that oftentimes are not apparent in some of the clinical documentation that we get from facilities, but that's where it's valuable to have our case managers come in and try and tell the full story around what's going on with the member, things that we might not have seen in the medical record, things that might be impacting their family or other challenges they're facing, so that as we're making decisions, we have all of that information to inform us. And then we're also using that setting to ensure that as we're authorizing care, that our case managers that are working with members directly are in sync, so that we're able to tag team an approach to make sure that those needs are getting met, and that there's going to be smooth transitions between where we're directing members for care, that they're not going to face a challenge with authorization, and we can go ahead and get those processes started ahead of time so that there's that seamless experience between the two. And this has been working quite well, particularly with cases that are very complicated or complex, we would say. It really helps us to strategize as a team, both in the immediate but also longitudinally, which I think is really what we're trying to move towards, is that longitudinal recovery. The next slide. So I want to talk a little bit more about the care navigation that we're doing with members that are needing help getting connected to community services. So next slide. So one thing we have established is what we're calling the Healthcare Services Hub. And what the hub is, it's a set of specially trained care coordinators, they're non-clinical, who have received more advanced training around the behavioral health continuum of care, around common behavioral health diagnoses, and have also been trained in some of the core principles of mental health first aid, so that they understand how to communicate with someone who may be having a behavioral health experience while on the call, with respect and dignity. So this team would field calls that have come in through customer service, primarily for members that are looking for help getting connected to services. They will evaluate the member for what types of services they're needing, what types of providers they would like, trying to take into consideration demographic preferences and needs as they are looking for the appropriate providers out in the community. The coordinators from the hub will then go and do that research that's necessary, come up with a short list of providers where we have verified availability and that it matches the member's needs or preferences the best that we can. And then we'll work with the member to try to get those appointments scheduled if the member's needing for us to do that. So they're also able to help get the member connected to other social determinant of health referrals out in the community. So if it's a food bank or housing needs or anything like that, they're equipped to provide those referrals if a case manager is really not needing to be involved. And we found this to be extremely helpful, particularly for members who have tried doing this on their own and have become exhausted and contacting behavioral health providers. Everyone's full, no one's returning their phone calls, these types of things. And what we don't want is for folks to give up on accessing behavioral health care. And so this role has really taken that burden off of folks. And we've heard that time and again in feedback from our members. So next slide. So what we're now working on the second half of the year, we've gone live in this relationship with Providence January 1st, is we are now looking at what type of a digital ecosystem do we need to create that's going to meet the needs of the PEBB population, of the Providence population in general, because rather than looking at all the solutions that are out there, which are many, and it seems like there's more that are coming on market every day, really taking more of a data-driven approach, looking at what are the needs of the population and which of these solutions would help to best meet those needs, so that we have a robust suite of digital solutions that are going to meet both the mental health needs, addiction, Virtual care for addiction is really key for me in making sure that we have that available. But also looking at any other specialty point solutions that might fit into this, where we're seeing significant prevalence in the population. So Dr. Geiger and I have been talking through this quite regularly, evaluating a number of different digital solutions and wanting to be quite thoughtful before we start bringing folks on and creating this ecosystem. But this is giving you an example of where we're moving towards. This would be an example of what that ecosystem would look like, identifying first those clinical needs and then having the solutions that would be able to specifically target those needs that have been identified in the population. So the next slide. Dr. Geiger, this is back to you.
Great, thanks, Dustin. Yeah, I just wanted to talk a little bit about the network and then touch on how the Behavioral Health Concierge Program, which was a new service made available to PEBB members, PEBB and SAFE members as of 1/1 this year. So next slide. So, one of the tasks of bringing this service in-house obviously was building a network. And so this is a representation of provider types, which is, I think, really runs the gamut of mental health providers, as well as basically every level of care available here, outpatient through inpatient, intensive outpatient, partial. It's been interesting with this in the time of COVID, how many of these programs actually have been able to successfully pivot to a virtual setting, although that may have affected some utilization for in-person services in favor of virtual. But as you can see, we've got the kind of the full continuum of types of providers. Next slide. And I just have a map of where the providers are, and I think obviously we have more providers where we have more population in general, and there are areas of the state that are much less populated and where we're struggling to find providers, which is really where I think the telehealth solution slots in. We do have most providers acknowledging on their account or their profile that they're accepting new patients, the vast majority of them, although sometimes that can be outdated. And as Dustin mentioned, that's where the hub comes into play to help folks get connected. But looking at this, obviously we've got a ton of providers in the major population areas. But what about folks who are on the coast or Eastern Oregon? So I wanted to use this opportunity to talk a little bit about the concierge program. You could move to the next slide. So Behavioral Health Concierge Program is something that we're very excited about. I heard just before this folks talking about value-based care, and so this is an example of us trying that out. Behavioral Health Concierge is a program that actually initially started as a benefit for Providence St. Joseph's caregivers, and the idea was we wanted to make access very easy for our own employees. And so the program started in that way. And basically they became a provider of EAP services for our own employees. And that has been in place for 2.5 years or so. It was a great program, great staff. We really liked the model. And we thought this would be an excellent opportunity to partner with our delivery side colleagues to offer some of our groups this service as well. And so we did that. We partnered with them and came up with an arrangement to offer the service to PEBB members. And so it's been available, and there's been uptake. The model of care is these are predominantly master level clinicians delivering care via telehealth. Some of the features I think that set it apart from kind of typical care is access. We have a performance guarantee built in for access, and I think right now they're getting just around 85% of people are getting an appointment within 1 week. These PEBB members, and though I'm told that the folks that can't get in within a week, it's often the member schedule that's getting in the way, not the service. So I think it's really addressing an access issue. It's also set up with an alternative payment model where it's billed as a case rate, and it really includes basically all necessary care over a 90-day period of time. And the care is, like I said, master's level clinicians providing telehealth. The theoretical framework really is practical and solution focused. So the goal is really to kind of resolve the issue by teaching new skills, strengthening existing strengths, and it's also a blended care model in that it's coupled with a digital solution called Silver Cloud, which is a computerized CBT, cognitive behavioral therapy platform that the therapist actively, basically prescribes and then includes in the treatment experience. So questions are asked, the digital experience is kind of incorporated into the session. And right now we're seeing, on average, when PEBB members are using the service, the average is about 5 to 6 visits with the service. And so it's still pretty new. We're less than, we're in month 8 here, and we're working on getting the uptake up. But we really do think that this is an exciting opportunity and a way to address kind of the disparity of population, because all you need is technology to be able to get to the service, and we really like the access piece. So I wanted to mention this, the PEBB concierge service. Next slide. And then just a couple comments about some quality initiatives. I think year one, a lot of effort has basically been to get this thing off the ground, keep it running, building the network, troubleshooting. As you can imagine, we moved the management of a significant portion of the benefit to almost 500,000 people. So it's been quite a task, and has kept us all very, very busy. But in terms of quality and reporting will be coming. I think we're developing those reports, but it's still pretty early. If you move to the next slide, one of the things we're looking at doing is measuring satisfaction using the ECHO survey structure, standardized survey, and so that's being built. And actually, I think the 16th was yesterday, so that's just getting mailed out. So I wanted to comment on that. Trying to seek feedback. It's kind of a random sample of members. We want to receive feedback about how this is going. And then, we'll have something to report out here November 19th is our goal, to be able to have a final report available about that. Next slide. And then just a couple quick comments, a lot of words here, but the focus here will be on daily operations. Dustin reviewed our care management team. We want to monitor how we're doing in that way. The care management and alignment, I think we've been, like as Dustin mentioned, very intentionally structured our program so that those two groups are interacting on a regular basis. I'm on 4 hours of calls every week with teams, Providence Health Plan employees, Beacon employees, working together as a team. We really think that that's where our secret sauce is going to be with this initiative. And then some smaller projects around looking at an analysis about kind of, what's our member communication look like in terms of print and website, and then reviewing document on our quality improvement measures. So just a couple comments about that, kind of your typical things you would expect. And then I think we just have one last slide and then probably time for questions. I think we just maybe have a few minutes. This, I always have to have a data slide, I think, and we're early and we're, reports are being built. What we did here is just to look at utilization. This is first 3 months of the year for 2019, 2020, and 2021. We wanted kind of an apples to apples. COVID kind of put a wrench in the 2020, but first 3 months probably is pretty similar, as March was kind of the main month affected. And we've seen a huge differential in utilization. I mean, it's kind of Standard outpatients about the same, maybe a tick up in intensive outpatient and inpatient down a touch, but these are all pretty close. This partial hospital number being a little bit low, maybe that's an effect of the tele in person versus not. Not everybody was able to kind of pivot partial. So that could be a signal there. But again, this is just a little bit of a sample. Anyway, well, that I think concludes the slides we have. Like I said, we're very excited about this. I was excited about this opportunity. I had a, kind of a dream job prior to coming to the plan, and when I heard that this was going to be a possibility, it was kind of the perfect opportunity for me to make that shift. And so we really want to make this an excellent experience for members, and we're confident that by integrating mental and behavioral health together, we'll be able to provide a seamless experience for members, improve outcomes and their experience overall.
Dr. Geiger, we have a question from Sean Parkman.
Hi, thanks for the presentation. This is very exciting and looks thorough. Integration, the concierge service seems like a great direction. This is probably one of the topics that I get the most sort of random questions from members about. People just reach out to me, and so the slide about availability doesn't really ring true to me based upon the experiences that I get directly. Is people are like looking at Providence's website or whatever, and they're calling people, and they say that they're available. You call them, and they're like, we're not taking any, and it ends up being like this kind of like week-long process where they're like calling, and they kind of get 3 responses. Like 1, no response. 2, no longer taking Providence insurance. 2 or 3, no longer taking new patients. Really common. And some of what may be happening, so I'm really encouraged that there's a survey that might bring some light to this, because that's, those are people clearly that are having challenges, and so they're reaching out to me, but there's a lot of them. So I'll be curious to see what that shows. But I do have a few sort of specific questions about the network, So in my time in looking into this particular area, I have been told, and I believe, based on some, the experiences of those around me, that there is a general behavioral health shortage, sort of society-wide, and that the primary cause of this shortage of behavioral health professionals is the difference in compensation, like lower compensation. So I'm curious have you tried to address that directly? Higher compensation rates or like competitive this and that. I'm just curious like how you addressed it, because I suspect part of your answer is going to be this kind of full court press, so to speak, on the different types of behavioral health professionals in your ecosystem. But I'm curious if you have thoughts on that directly, because I hear that very often. And my second question is perhaps part of the challenge for the people that are reaching out to me is that they're looking for a particular type of person, behavioral health specialist. And from my experience, it's not really all that important what their credentials are. It's what their background is. Like, does this person understand me? Are they of my same race, of my same gender, etc. And I'm wondering what thoughts you have in putting together this internal network in relation to diversity and availability of that diversity in the network.
Okay, a couple of points here. in terms of the in terms of the compensation, I think that there are a number of challenges with, recruitment. And I think that one of the, psychiatry in particular, psychiatrists, and I would include nurse practitioners, that field is among the highest likelihood of not taking any insurance and being like totally a cash practice. And so there is a bit of a current, swimming against the current in that you can do that. And it remains one of the fields where that's kind of, it's easy to have your own practice, low overhead, that kind of thing. So I think there is that challenge. I think, as we entered the market, we tried to be competitive. We tried to, Optum had a network, and I think the targets were to be, competitive with that. It's all balanced against, the premium and the 3.4% and that challenge. But I think that, we're trying to be competitive. And I think that, again, our hope is that over time, we can leverage the local experience and reduce administrative friction. That it's another reason that providers maybe just don't want to deal with an insurance company because it's paperwork and it's maybe perceived as a hassle or the like. So it's a little bit of a vague answer, but that's kind of how we approached it. And then I did try to do a data poll on the diversity question. Which I think is a valid point. The data poll, it came back, didn't make any sense to me. So we're going back to try to look at that, see if we can get a better sense of this. I mean, I think, Oregon as a state, if we're looking at that as kind of the majority of our proprietary network, is not the most diverse state in the planet, but they're in the professional network, just based on educational level, may actually be more diverse than the actual state itself. However, there's also trends historically in U.S. mental health education, such that people of color, the BIPOC community may not pursue that, or maybe underrepresented in those. So there's also kind of an educational pipeline challenge. But we do appreciate that folks are, wanting somebody who gets them. And, one of the most powerful pieces of research about whether a mental health treatment or a psychotherapy is going to work is the connection between the member and the treater. And that's more important than experience or technique or anything like that. It's just literally how close is that connection. So we do appreciate that, and we'd like to get that data pool to be a little bit better so we can maybe target areas that are deficient. But I think it's important. We have our work cut out for us. And then a comment about, I agree with you, the providers will tell us they're taking new people. The member experience is different. We try to update that when we can and correct that, but that is also kind of a swimming up current challenge for us. Because I agree, I think that the lived experience of members getting is not that every single person who says they're taking is taking. And so we try to correct that in real time. Did that get at some of your questions? I feel like it's a little bit of a...
Yeah, that's helpful. Thank you.
Thank you. Gosh, we sure appreciate you being here today, Dr. Geiger and Dustin Howard, for joining us. Does anybody else have any questions before I have them? Like we're good. I don't see any hands up. So now thank you again so much for your presentation. Now we're going to go back to Brian Olson and the Secretary of State's audit findings. And again, I'm sorry, Brian, for having to move you around on the agenda. I appreciate you being flexible.
No worries. We'll wait for Rose to get to the presentation. And while we're waiting, and Rose, we can start at the second slide. We don't have to start on the title slide. So while we're waiting to get started, board members, I'm Brian Olson. I'm your contracts team lead. I'll be presenting today some updates on progress we've made related to a few different Secretary of State audit recommendations that specifically relate to contracts. Although just a note that some of these updates do touch on some communication items because, as some of you may know,
The audit recommendations included both communication and contract type recommendations that at some times overlapped. Next slide, please. Okay, so what I'm going to do is I'm going to go ahead and I'll just read or recap the specific audit recommendation that I'm addressing today and then give a brief progress update, and then I will just continue moving along in that format. Feel free to interrupt. I have a couple notes that I'm looking at, so I may not be able to see a raised hand. Just interrupt me with any questions or comments you see fit. So the first audit recommendation related to contracts reads, regularly communicate to members further educational opportunities in addition to open enrollment for members to learn how to better understand the details of their insurance coverage and how to utilize their benefits to make optimal health and cost decisions. So we have a number of updates. We have increased our stakeholder engagement to assist in various types of communications. For example, over the past year, actually year and change, we've partnered with Uplift Oregon, which also includes PMAC and the Worksite Wellness Coordinating Council, inviting Uplift Oregon to those meetings and discussions. We've also established, as some of you know, a health equity work group for both OEB and PEBB, as well as some related infrastructure and processes that essentially will require staff to solicit feedback from our diverse membership before we even bring a potential recommendation to the health equity work group. We've also improved the communication tools that staff will have available to them in the future through how we've developed and designed the upcoming consultant RFP. That RFP has not hit the streets, so I am not going to share details of what those items will look like. Next slide, please. Okay. Let's see, make sure I'm on the right slide. All right. So the next recommendation related to contracts reads that we will periodically communicate to employers, members, and stakeholders about the board's ongoing administration of benefits, cost containment efforts, and the anticipated effects of affordability and accessibility of healthcare coverage to stakeholders, including employers and members. To this end, the past few years, we've held a PMAC meeting, and actually an annual PMAC meeting each of the past few years, where we include a lot of this type of different information. We present to them, various insurance concepts about how insurance works, how premiums are built, what the differences are between fully insured and self-funded arrangements, as well as utilization information, enrollment information about where our members are located, et cetera. This year, we expanded that annual PMAC meeting and invited the Worksite Wellness Coordinating Council, as well as our new Health Equity Work Group members, as well as all of PEBB and OEB staff. Again, bringing in a number of different stakeholders and committees in one room, where for 3 hours once a year, we can kind of give everyone a broad-based kind of sense of what our business looks like, what our issues are, and not only recapping the previous year, but also looking forward to what we think the biggest challenges will be on the horizon. Okay, next slide, please. So the next recommendation reads to consistently collect, analyze, and share results of employers and members' experiences to better inform board decisions. So again, the current Health Equity Work Group and related processes infrastructure that we're currently implementing should go a long way to ensure that staff and our committees, at least the work that goes through staff and the committees, are gathering the adequate feedback from various diverse groups and from our members before anything even percolates up to you guys, the decision makers, the full board. In essence, any policy or operational recommendation that at least would go through the Coordinating Council or PMAC will go to the Health Equity Work Group and will be subject to this Health Equity screening tool that captures a lot of this member feedback. And essentially, until the health equity work group feels comfortable that we have gathered enough member feedback and experiences to move the potential recommendation along, the board just won't hear of it. So it kind of forces staff and Mercer and our other partners to really do a better job at vetting potential recommendations before they even come to this table. Okay, next slide. So the next recommendation recommends that we promptly enhance oversight and clarity of consultant and carrier contracts, and there's 4 different sub-recommendations. So I'm going to start with just kind of a general response to us promptly enhancing oversight and clarity of those contracts. So in general, I'm going to start by showing that we've actually expanded our contracts team, essentially almost doubled in size, maybe more than doubled in size, so that we could not only keep working on the normal annual renewal process work, as well as the occasional RFP and other duties as assigned, but also so we could start working on process improvements, changing the way we do our work, changing the way how we work with others, both within OEB and PEBB, but outside with various stakeholders. Basically, increasing the size of our team and bringing new experiences and expertise to the table just will allow us to do a better job at juggling what is many priorities given our staff size. We've also implemented new monthly account meetings with our consultants, and those new monthly account meetings are focused specifically on deliverable review and approval, as well as tracking the year-to-date budget information. This is where, as a group, we review the deliverables and then give a initial approval of the invoice and charges. And this meeting is separate from, and in addition to the meeting we have with Mercer and leadership every other week to assign specific work and to decide priorities. Also, in general, we have now mapped out the entire annual renewal process in detail, and not just the consultant and board-centered renewal process that happens, January to May or June, but everything that happens with the consultants and staff before, afterwards, and during. And we've done so for a lot of reasons. One, I think we find ourselves every time there's a new employee or board member spending a lot of time trying to explain how this annual process works and how it never ends. And so we thought having a visual certainly will help. More than that, strategically, it's helped us identify the areas where we can improve our monitoring and oversight by scheduling a few different touch points throughout the year where staff and our experts can do a quick kind of regulatory check, do a survey of staff, and whatever compliance or other performance issues that we may come across our desk that are separate from the claims and other performance work that Mercer does, we would have an opportunity to integrate that into the renewal process so that it's a little more seamless. And so that way, too, we're still addressing the things that happen closer to real time versus some of the reports or other reporting that's based on claims that has a bit of a lag. And then in terms of the sub A, the first sub recommendation, and that's to clearly define deliverables. And this is just a note, we started with the consultant contract because that was one of the primary areas that the auditors focused on. And we have worked with numerous staff and new members of our contracts team to better define all of our business needs related to consultants. And developed a much more accurate description of the work and services we'll need in the future, separated out by the work we know is routine, we need every year, like the renewal work, versus work that's really at our discretion based on our needs. So things like auditing, we don't do full claims audits every year, but we have the right to if we think that's a high priority. And again, I'm not going to go into details about how the RFP sets us out because it has not been released. Let me stop really quick survey. Are there any questions, any concerns, other thoughts? Okay, next slide. Let me pull my notes back. Okay, so the next sub recommendation B reads to more actively monitor and enforce deliverables. So in our current state, as I previously mentioned, we're identifying and implementing new staff touchpoints in our annual renewal process to ensure the most recent contract compliance information is considered in your renewal decisions. As Mercer previously mentioned in their presentation, the future state is that our newest team member, Ruby Castaneda, has been working with Margaret Smith ESA and IWG to develop and work on implementing a new set of performance measures across PEBB and OEB medical carriers that will just be a heck of a lot more meaningful in terms of performance overview, oversight, and monitoring than our previous reporting regime or our current reporting regime that we have in contracts now. And the next sub-recommendation reads verifying invoices for accuracy and contractual compliance. I've already mentioned that we increased the monitoring of the consultant contracts through those new monthly account meetings. Next slide. The sub-recommendation D calls for a more comprehensive program for identifying improper claims. So one thing we have already done is we did build additional budget into our consultant contracts on both the PEBB and OEB side and made sure that the contracts included within their scope the ability to audit as we saw fit, and they certainly do. So we have the ability and the budget to do it. It's really just a matter of how we prioritize, like claims audits among other work that we would rely upon our consultants to do on our behalves. One thing I will say, and that I just previously mentioned, is some of the performance guarantees and measures that we'll be working on and implementing in our contracts will speak to some semblance the improper claims. So we will probably have things like claims payment accuracy or other measures that just speak to whether that work's going on accurately or not. And if those measures aren't part of the new overarching, I guess, regime, we still might have a handful of reports that get to that information. So all that is to say that it's kind of a work in the progress in that we need to finalize what we're going to do with the performance guarantees and with IWG. And then as a staff, we'll likely need to fill in some gaps based on our business needs and based on other audit recommendations. So with that said, are there any questions, any concerns?
If I could just make one comment, this is Ollie. I just wanted to say hats off to Brian and his team. I think, the progress that they've made on the Secretary of State findings has really been tremendous over the last year. And I think for the first time, really got, almost enough resources to cover the tremendous growth in this area and really the requirements that are part of our contracts team deals with on a daily basis. It always continues to grow, especially as we get into these big RFPs. So
I appreciate it. And I know Claudia and I, life is a lot easier with having Ruby and Sheila, for those of you who've worked with Sheila Clausen and Rebecca, who have also been working with the contracts team. It's just made life a lot easier, and they have all been rock stars. They're performing really well, and they've made the contracts job and work a lot easier.
Thank you so much, Brian.
Thank you.
Cindy, did you want to just touch on telling us to make sure we check with the slide deck and go over your communication plan? What would you like, since we're at 12:06?
I feel like, thank you. I feel like people can probably review the timeline itself on your own. It's pretty self-explanatory. Just a couple things that I want to point out. We are going back to mandatory open enrollment this year, as everyone knows. So we're really going to focus on that during our open enrollment communications. We're also going to maintain mostly electronic materials this year. It worked really well last year. The one exception to that will be the summary of benefits. The carriers have already reviewed and updated their information on those, and we will plan to send that out kind of mid-September, I think, to align with when the open enrollment guide will be posted on the website. So the materials that you have in your packet will kind of line out when our webinars are going to be, when the sneak peek information will go out. Most of it is going to be electronic though. So anyway, if you have questions, feel free to email me. I don't think I need to take up any more of your time going through step by step what they are, but if you have questions, be sure to let me know.
Wonderful. Thank you so much, Cindy. And earlier, Rose said we had no public comment, but I just want to open that up to anyone that's on the line. We had public comment. Ali, did you have anything at the end here that needed to be brought up?
Nope, I think we're good, Kimberly. Okay.
Well, it looks like I'm going to call this meeting adjourned. The PEBB board of August 18th, 2021 is now going to be called adjourned. And thank you so much, everyone, for joining us. And it was good